And Studnick, Deputy Director, Mecklenburg EMS Agency. Again, thanks for taking some time to chat with us today about the state of Medic and our response to COVID currently. So the situation with COVID, as you all know, is rapidly changing within our state and within our community, and Medic has been impacted just the same. On Tuesday, the day before Christmas, or the Tuesday before Christmas, we had three patients three employees in isolation due to COVID. So to be clear, the Tuesday before Christmas, we had three employees in isolation due to COVID. Now, a little less than 2 weeks later, we have 33 employees in isolation due to COVID. And so we know that COVID is spreading rapidly in our community, and it is impacting Medic the same as other members of our community. At that same time, we've seen an increase in COVID transport volume, where we were doing 4 to 5 COVID transports per day. We are close to the peak number of COVID transports that we've seen in our community, around 25 to 30 a day. Now that number varies from day to day, but we have seen a peak within the last 7 days of 30 transports of COVID positive patients in one day. And that is fueling a rise in our daily transport volume. If you take into consideration our increases in transport volume due to COVID-related illness, COVID-related absenteeism of our employees, and then our generalized staffing situation coming into this last wave where we are short staffed relative to our budget, we are seeing issues being able to produce the number of ambulances per day we need to match volume. Therefore, in the last 4 days, we've made some changes to how we respond to certain types of calls within our community. So first, we have evaluated data in the past to identify a low acuity subset of patients. These are patients that call 911 and have some sort of medical need, though they don't need a rapid ambulance response. The disposition of these patients remains low acuity. Either upon our arrival, they refuse transport to the hospital, or they're transported our lowest priority, very low acuity patients. We transitioned these patients to a slower response time in October, 30-minute response time, as opposed to our standard for mid-acuity patients of 12:59. In order to further protect our response times for our sickest patients, we received approval from our medical control board and agency board last week to further extend response times on this subset of low acuity patients. The response time criteria for those patients is now 60 minutes, moved from 30 minutes. We've had 60-minute response time criteria for other low acuity patients in our system. And so this is just increasing the number of patients that we will arrive on within a longer window. About 30 to 40 extra patients a day will be triaged into this longer response time criteria. So that's change number one, a change to our response time criteria for very low acuity patients. And we do that so that we can better manage our resources and be able to respond to our high acuity patients. Second, we have instructed our EMTs and paramedics to continue to have conversations on scene with patients about the relative benefit of ambulance transport in a low acuity setting. Patients may need to see a physician or receive care at a hospital or a clinic or an urgent care, but an ambulance transport may not benefit them in that seeking of care. And so we are having further conversations with patients about the need for ambulance transport and reminding folks that if you're seeking COVID testing, if you're seeking a vaccine, or if you're COVID positive and worried, ambulance transport is not an appropriate method to receive medical care. You will not receive a test any quicker, and you may not receive care any quicker if you're a low priority patient arriving by ambulance. And so it's important to let the community know that we're going to be having these types of conversations with you, and that if you are having a serious emergency, we will recognize that and take excellent care of you right away. and not necessarily mention any of those factors beforehand. We're reserving these conversations for low acuity patients. And finally, we've made some adjustments to the non-emergency transport work that we do within Mecklenburg County. We have a responsibility to decompress the hospitals by discharging patients to home or moving patients between facilities. For the next 30 days, we have limited the number of non-emergency transports we're going to do, specifically focused on moving patients out of county. We don't have the resources to help discharge patients to locations outside of Mecklenburg County, so we'll be ceasing that work for at least 30 days. And we're working with our hospital partners to figure out how to best manage patient movement between facilities or out of facilities. That work must continue. The hospitals need capacity, but with limited resources, we have to think about different ways to manage that work. So really, COVID has had an impact on our workforce, and we are short-staffed. Due to that, we've made 3 changes. One change to about 30 or 40 responses a day, where we'll have a response time target of 60 minutes, up from 30 minutes. We're having direct conversations with patients about the need for ambulance transport and whether or not they could seek care through some other mean. And we've made changes to how we are supporting our hospitals in our non-emergency business. So with that, happy to start answering questions. I think Lester said if you raise your hand, he can recognize, and then we'll go around the room and answer any questions folks may have.
Thank you, John. We have Carolyn Hicks from WBTV. I'm going to have her unmute.
Thank you for taking my question. I just wanted to ask you I know you mentioned don't call 911 for a COVID test. Are you having that happen often where people are calling 911 for help getting COVID tests? And can you kind of explain like what that situation looks like and why people should not be doing that?
Yeah, so the scenario that we see most often when someone calls for a test is that there's family members within the household who have COVID, and they don't know how to go seek testing. And so they call 911 to see if we can test or help facilitate testing, and that's not a service we offer. There are many community partners in Mecklenburg County that have testing infrastructure up. Some of the wait times are long, we do understand that. But that's not a service that we offer. And if family members in your household have COVID, we recommend that you go get tested, but we ask that you not use the 911 system or any emergency services, whether that be the emergency department or urgent cares, to get tested, but use the other infrastructure that's here in Mecklenburg County.
And then I just had one more question. In September, I know that the state said they were ordering ambulances from FEMA and personnel, and they said some of those were going to be distributed across Mecklenburg County. I'm just curious if that ever happened, if you guys ever got that support from FEMA.
Yes, we did request support from FEMA in September, and we did receive ambulance strike team resources for about 4 weeks. Those resources left us the 1st of November. 2 weeks ago, I made a request of local emergency management to return those ambulance strike teams to Mecklenburg County. We made a request for 25 ambulances with 50 personnel. My understanding is that request has been sent to the state of North Carolina, who has forwarded to FEMA, and that they are processing that request, and that we will hear within the coming days or week if we will receive additional ambulance strike team resources.
All right, thank you. Next, we have Lana Harris.
Hi, thank you. So you have a service that will let people go to hospitals via rideshare. You talked about that the last time we talked about the staffing shortages. So are people using that, or do you need people to use that more?
Thanks for that question, Lana. Yeah, we're on a certain subset of patients who go and talk to a nurse advice line and then come back to us for transport only. We offer those patients we offer those patients a Lyft or an Uber to help facilitate their transport to the hospital. Many patients still refuse that request, and we end up sending an ambulance. And the wait time for an ambulance that comes back from a nurse advice can be up to 90 minutes. And we explain that to the patients that you will likely get a Lyft or an Uber to take you to your destination much quicker than you will an ambulance. And we would encourage individuals who call 911 and meet those criteria to accept that Lyft or Uber ride to the hospital. You will likely get quicker service when we offer that to you. And we're offering it to you because the questions you have answered during telephone triage indicate that it is a very safe and appropriate method for you to have transport to the hospital. So we'd ask those folks, if offered when you call 911, to take advantage of that service.
Thank you. Now we have David Hodges from WBTV.
Thank you so much for your time and being willing to update us on this. Just a couple of questions on the new time frame for responding to these calls. Am I correct in that these are the Sierra calls first and foremost?
Yes. Okay. Thanks for making that connection. We took Sierra calls and we extended their response time and then removed first responders from that response.
Okay. And are there additional, from when we spoke before, these were the low acuity calls, are there an additional section of types of responses that have been added to this more than what previously existed? So have those expanded? What would be now part of the Sierra calls?
No, we have not expanded them. We have just shifted their response time, though we are continuously evaluating other call types to determine if they would be safe to move either into the Sierra 30-minute or 60-minute bucket, though we have not expanded it. We have just shifted the response time.
Is this a temporary change or a permanent one?
We're going to reevaluate the effectiveness of this in 30 days at the end of January. And if our safety measures meet our predictions, we may recommend that this response time criteria remain the same for these patients. However, if we have concerns about patient safety, once this surge is passed, we can revert them back. And so it's a to be decided question, and we will base that on the safety data that we're currently evaluating.
And just last follow-up real quick, just to make sure I understand this. This is now going to be a subsection of calls where the response time will be potentially up to 60 minutes, and there will not be first responders. So what is your biggest concern about how this could go wrong?
So the great news about these call types is that there is a very low probability that an individual will have an acute illness in this bucket. My concern for folks is that they don't understand the low acuity nature of their illness and know that we will come and assess you and that we will be there to take care of you. It is just going to take us a little bit longer. And that's not the type of service our community is used to, which is why we're having these types of conversations today to let folks know that we believe this is safe. And you're going to experience a longer wait time if you're triaged into one of these call types, and know that we will be there. And we're doing this to protect our high acuity patients. And so you will feel a difference in that response time.
All right, John, now we've got Robin with Fox 46.
Hi, John. Thank you so much. I had two questions. One, I just wanted to make sure that the high priority calls, the response time is not impacted with those. And then also, is the city and the county, City of Charlotte, Mecklenburg County, are they able to provide you guys with any resources, or at this point, is it really just you need more bodies, you need more paramedics? Have you thought about private ambulance services, anything to help along those lines?
Yeah, thanks for your question. So first question about high priority responses. Our response time requirement for our highest acuity patients has not changed. And our full focus and effort is to making sure that we can arrive to our sickest patients quickest. And that's why we're making these changes. Secondarily, we've received tremendous support from Mecklenburg County throughout the entire pandemic. And the situation as it stands today is we need to be able to hire EMTs and paramedics to fill the openings we have. And we need to crest this next COVID surge and pull people back off of isolation. And so really it is a person problem. We need people. We've been hiring. We hired a class of 11 in December, and they are about to be released into the field. And then we have a class starting January 11th that I believe is 13 to 14 new employees. And so we're continuing to chip away at our deficit. It is just going to take time to identify those folks interested in the field and get them recruited in, trained, and then deployed into the system.
Robin, did you have any more questions for John?
You did mention the county has been helpful. What about the city of Charlotte and the resources there?
Yeah, so the city of Charlotte, we're partners with the city of Charlotte's our largest first responder agency within the community. And they have, as they always have, been a great partner in supporting first response, making sure that they have teams in place to assess patients initially, and then provide good report and care and transition to our teams. We have had conversations with the city of Charlotte about alternate staffing models. However, they have to maintain their readiness for their services as well. And so we have a good relationship as first responder and EMS provider, and we're very thankful for the continued work they do to help support the EMS system as first responders.
Thank you, John. I have a question from Dana Irvin from WFAE.
Thank you. So I'm just wondering, first of all, are there just two categories, low acuity and high acuity patients?
No, we have several categories. We have a high acuity category. We have a mid acuity. Then we have low acuity that receive an ambulance response, and low acuity that first go to a nurse advice line for healthcare advice prior to dispatching an ambulance.
I see. Thank you. And you mentioned that you're having to hire. How many down are you, not just from COVID, but from attrition?
Yes, our full budgeted staff of field providers is 374, and we currently have 314 available to work, plus the 11 that are just being released from new hire time. So that puts us at 325. So a pretty significant shortage.
And is that shortage from COVID? From do you have any breakdown on that?
Yeah, so our turnover has been relatively constant throughout the pandemic. We've seen an increase in turnover in the last 3 months, but the bigger issue is that the hiring cycle slowed down a lot during COVID. And so we didn't have as many new graduates from EMTs and paramedic programs. There's just kind of a generalized workforce shortage that is impacting EMTs and paramedics as it is many other industries. And so while our attrition rate is somewhat elevated, but not out of control, the issue is we haven't been able to backfill those people at the same rate that we had in past years. Okay. And so we really need to focus on hiring at a higher number than we attrit, and that's how we'll get through into the other side of this staffing issue.
Okay, and so just to recap, then this will only affect the low acuity patients, those who are either triaged by a nurse or, and there will be no effect for the mid acuity patients.
No, we have two response time levels at high acuity and mid acuity. That will not change. It is only low acuity patients that will have up to a 60-minute response time.
Can you just tell me the response times for high acuity and mid acuity?
10 minutes and 59 seconds and 12 minutes and 59 seconds.
Thank you.
John, can you give an example of a low acuity call?
Low acuity calls are patients that may have suffered some type of injury but are conscious, alert, breathing. They have no change in mental status. They never went unconscious. Generalized illness where they may have a cough or a fever, but they do not have difficulty breathing. And so really, low acuity patients are patients of exclusion. They don't have high priority symptoms. They're fully awake, fully alert. They're not having chest pain. They're not having difficulty breathing. Those are what fall into our lower acuity buckets.
Okay, we got another question from Nana Harris.
So that was my question, examples of low acuity. So I'm good. Thank you.
Okay, hopefully David Hodges doesn't have the same question.
Just one last one. Any update on continued negotiations with county fire departments and the city fire department on how they will respond to your new response procedures for these Sierra low acuity calls?
Yes, so we had a meeting with the city and town and county fire departments on Wednesday prior to the Thursday go live of this response criteria, and we explained to them the fact that we would have a longer response time and that we would not be dispatching town, city, or county departments on these lower acuity calls. We had a great conversation explaining the process. They were supportive of those changes, and we continue to talk with all of our first responders throughout this current surge to make sure that we're all clear on our responsibilities and that we have good line of sight on making certain we're treating our highest acuity patients the best we can.
John, you have one more question from Caroline Hicks.
Okay.
Thank you. I just was curious whether hospital capacity is causing any issues for you guys, or in terms of when you decide where to take a patient. Are you ever being turned away because there's just not enough room, or how is that affecting how you do your job?
Yes, our hospital turnaround time, so the time it takes from when we arrive to the hospital until we're clear to and available to go to either our next post or our next call, has been extended over the last 2 to 3 weeks to the highest point, frankly, that we've seen in the pandemic. And that is largely due to the high amount of volumes that hospital emergency departments are seeing and the higher volumes that they have generally in the hospital. And so we're working with our hospital partners to reduce those hospital turnaround times. But the longer we stay at a hospital, the less we are available to respond to that next call. And it's critical that when we arrive, in a reasonable amount of time, we are able to transition care to hospital staff and then go on about our next assignment. And so that is a barrier right now. And we are working with our peers at all of those institutions to make sure we manage that issue to the best of our ability.
Thank you, John, for your time. Thank you, everybody, for all your questions and your